Thanks for having me over for the web chat on IndianRadiologist.com. Since most of your audience are practicing radiologists in India who don't have formal experience and probably practice experience with nuclear imaging and therapy, I thought it might be best to discuss certain key concepts. Let me first start with the core concept of the tracer principle, which is the basis of nuclear imaging and therapy. So you can think of nuclear imaging as a functional imaging modality in contrast to the mostly anatomic techniques like ultrasound, CT or MR. At the heart of it is the radiopharmaceutical, which is a combination of a radionuclide that is attached to different various types of pharmaceuticals, man-made molecules or drugs, and this combined product gets administered to patients. The radionuclide merely emits the radiation, which gets captured by the modern day gamma cameras or nuclear cameras, whereas the pharmaceutical determines the tissue or organ extraction, distribution and clearance, and thereby identifies abnormalities in those processes. The radiation emitted from the patient then gets captured by the cameras, and using complex computers and electronics, we get the images that are used for interpretation. And diagnosis is basically recognition of imaging patterns of abnormalities in extraction, distribution, and clearance. Now, what is a radionuclide? It is an atom that has an unstable nucleus, which in its quest of achieving stability emits energy in the form of ionizing radiation. The ionizing radiation that we use in nuclear techniques include gamma rays for imaging and alpha and beta particles for therapies. Some common examples of imaging radionuclides are technetium-99m, which is the workhorse in our general clinic that we use for a whole range of exams, including bone scans, cardiac scans, kidney scans, etc. And then you have fluorine-18, which gets combined with the glucose analog, fluorodeoxyglucose, which serves as the workhorse in the PET clinic. On the therapy side, you have the prototype beta emitter radioiodine, which is used to treat a variety of thyroid ailments. And then you have the new kid on the block, the alpha emitter, radium-223. Now there are many other radionuclides that we use in clinical practice, but these are the most common ones. So hybrid imaging is a very promising and incredible advancement in imaging that has happened over the last couple of decades and now has been fully incorporated in everyday clinical practice. It has allowed either sequential or simultaneous combined functional and anatomic imaging. Common examples of hybrid imaging techniques include Spec CT. Spec stands for single photon emission computed tomography. Then there is PET CT that most of your audience should be familiar with, and the newest entrant in this is the increasing popularity of PET MR. So let me show you some examples of hybrid imaging technology. The first is a Spec CT bone scan on an elderly male with neck pain. He had an MRI done that showed multi-level cervical spine degenerative change. Now the question is, what abnormalities in the spine are causing his neck pain and radicular symptoms. So as you see on the cervical spine Spec CT, which is acquired as a sequential image set, though first with CT and then with the SPECT images, which are basically cross-sectional images on the bone scan, and then brought together using computer algorithms, and you get this combined fused Spec CT image. And here you see robust bone remodeling occurring at the C5-C6 disc space from disc-related degenerative change, as well as degenerative facet arthropathy occurring bilaterally at the C3-C4 level. Moving to the next modality, which is PET CT. This has essentially revolutionized oncologic imaging and has other cardiac and neuro applications as well. On the upper hand is a case of advanced or stage 4 lymphoma, where you see disease that has involved both lung fields and lymph nodes that are there on both sides of the diaphragm. So it's a very common technique used for staging patients with a variety of malignancies. The second example here is for treatment monitoring. So these cancer patients go through highly toxic chemotherapies or radiation, and you want to find out if these therapeutic options have been effective in treatment. Here you see a very prominent anterosuperior mediastinal mass that takes up glucose prominently, and then at baseline, and then after treatment you can see that the mass has only modestly decreased in size but has lost its metabolic signal, suggesting an excellent treatment response. And lastly, you have this example of melanoma involving the left maxillary sinus that had been treated in the past, and an MR showing contrast enhancement, suspicious contrast enhancement, and then we combine it with PET MR, and you see there is intense focal hypermetabolism in that same area of enhancement with corresponding low ADC values, findings that are highly suggestive of locally recurrent cancer. So these are three most common hybrid techniques that we use in this field. In fact, hybrid imaging has really given our field a shot in the arm and has taken us into the frontier of imaging. Theranostics, or also called as theranosis, comes from a combination of two words, therapeutics or therapy, and diagnosis or diagnostics. And that's where the theranostics or theranosis comes from. It's a relatively newer concept and has gotten a lot of attention in the last several years as it has the ability to provide personalized treatment to the individual patient. The concept revolves around using a radionuclide or a radiopharmaceutical for diagnosis of the patient's condition, and then using either the same radiopharmaceutical or a variation of that for the therapy. So the classic theranostic agent historically has been radioactive iodine, which has many different analogs, but the ones that we use in the clinic setting is radioactive iodine or iodine-131. It has the ability to emit gamma radiation, which allows for imaging, but it also emits very powerful beta radiation that allows its applications in therapy. On the left-hand side of the screen, you see I-123, which is an analog of iodine as well, but it's a diagnostic agent without a therapeutic arm that is used in diagnosis of very many hyperthyroid conditions. Example, Graves' disease with its characteristic engorged or butterfly-shaped thyroid gland, or you have the prototypical patchy nodular pattern with multinodular goiter, or the intense uptake associated with an intense hyperfunctioning thyroid nodule, also referred to as a toxic adenoma. So this agent is being used to come to a diagnosis, and once that is reached, it gets translated to using iodine-131 as a therapeutic agent, for treating the hyperthyroidism. On the other side of the slide is using iodine-123 in imaging patients who have thyroid cancer. Here again, you have small iodine activity being taken up in the left lung, seen both in the anterior and the posterior projection. Interestingly, some of these small metastases may not be very overtly identified, on conventional CT. In this case, you don't see a convincing CT abnormality, but the functional abnormality is highly suspicious of malignancy, and this can be further treated with radioactive iodine. The next slide is using iodine in the diagnostic realm after its use as a therapeutic agent. As I mentioned earlier, iodine-131 has both gamma emissions that allows imaging and the beta emissions that allow therapy. So we have patients come back usually a week after the treatment for imaging, and here you see an unfortunate young patient who has a multifocal recurrence in the neck as well as metastases in the lungs. There are other theranostic applications that are practiced. We use somatostatin receptor imaging agents, example gallium-68 dotatate, which then gets transcribed for therapeutic applications using the beta emitter lutetium-177 combined with dotatate. So just leaving this concept of theranostics out there for the audience.